All right. Hi, guys. So this is my presentation on renal tubular acidosis. This is primary care of the child too, and our class is by Dr. Brooke Hamilton. So renal tubular acidosis, or RTA, is when there is dysfunction of the renal tubule transport capability. There are four subtypes of RTA. The classic, or sometimes it's called distal, which it occurs at the distal tube defects, or primary RTA. Number two is bicarbonate wasting RTA, which occurs in the proximal tubes, or it's also called proximal RTA. The type 3 subtype of primary RTA, it mostly only happens in infants, and it's the only inherited type out of the four. And then type 4 is hyperkalemic RTA, which occurs with dysfunction of aldosterone, mostly commonly after relief of obstructive uropathy. Okay, so pertinent health information and subjective and objective information on this patient. So usually you'll see a patient who has failure to gain weight and height, especially weight. Polydipsia and polyuria are present. Muscular weakness caused by that low K. They may also present as irritable before meal times and then satiated right afterwards. They can also present with nausea, vomiting, and or constipation. Sometimes these patients will prefer liquids over solid foods. They may have a poor appetite, and in some cases, anorexia can occur, especially in type 4. Okay, so specifically for that PE, a lot of patients will present with a normal physical exam in the past. So their whole life, developmentally and physically, they've been fine. And then there is a slight change in their physical exam. When you look at the growth chart, there's usually an arrested growth curve at the end of the year, consistent with the prior year's growth. So, their whole life they've had this up curve, and then all of a sudden there's a downward of arrested growth, which is abnormal. Okay. So diagnostics. So the first step is the PDNP should we want to order serum electrolytes. We want to rule out hypokalemia, hyperchloremic metabolic acidosis. You want to order a BUN creatinine for that kidney function. You want to also see calcium, phosphorus, and alkaline phosphatase. You want to get a UA, which is preferred. The best time is to get a first morning void. You want to screen for glucose and the pH of the urine. And then if any of those lab results are abnormal, the PDNP should consider extra testing, which is on the next slide. So the second step, so if those labs are abnormal, you would want to run a 24-hour creatinine clearance to establish if the patient has a normal GFR to calcium ratio. This should be less than 4 milligrams per kilogram per 24 hours. And so we're looking at the calcium to creatinine ratio for that. And then the urine culture, we should do this anyway, right? In best practice, something's going on. We want to rule out a UTI with urea splitting bacteria, as they may elevate urine pH. So the pH may be elevated, but it might not be due to the metabolic acidosis. It might be to the specific bacteria that can cause UTI. So that's why you want to do that. And then you want to also order a renal ultrasound, because you want to make sure you can identify the anatomy correctly. And then also you want to rule out for the following disorders. So nephrocalcinosis, nephrolithiasis, hydronephrosis. Oops, sorry, I wrote that twice. And then obstructive uropathy, and then parenchymal damage. Okay, so this is a differential diagnosis that I got for RTA. So tyrosinemia, Wilson's disease, cystinosis, Ehlers-Danlos syndrome, multiple myeloma, pseudo hypoaldosteronism, and then there's a pyruvate carbolase deficiency, Sjogren syndrome, systemic lupus. So those two are kind of autoimmune and arthritic diseases. So those kind of go together. Okay, and then evaluation of the lab data. So once you have your lab data, you're really looking for the bicarbonate levels, the serum potassium, and the urine pH. So, and that will help you decide, to diagnose which type the patient has. So, as long as we've ruled out all those other diseases. So, for type 1, the bicarbonate is going to be less than between 10 and 20. You're going to have low K, and the urine pH is going to be alkaline, so it's going to be greater than 5.5. For type 2, the bicarbonate is between 12 to 18. You're going to also have low K, and the urine pH is going to be less than 5.5, so it's going to be acidic. Type 4 is greater than 17 for bicarbonate. It has a hyperkalemia, and the urine is less than 5.5 for pH. So that's the metabolic part. And then for the BUN and creatinine, if there's normal or near to normal, this rules out renal failure as the cause of acidosis, which is very important. So we want to make sure we rule that out. For urine culture, like we talked about, we want to rule out that UTI because certain bacteria do have their urea splitting, which can cause elevation. And then the urine anion gap. So the gap signifies low sodium chloride excretion, which causes decreased chloride in the urine along with metabolic acidosis. And if this is positive, this would another marker, it would suggest RTA. So diagnosis. So I do really like, it's kind of like a step down for diagnosis because this is a little bit confusing to me. And I definitely would refer a patient to pediatric nephrology if any of this came up abnormal. But for primary type 1, you're going to see low molecular weight proteinuria, hyperaminoaciduria, glucosuria, like we said, the glucose in the urine, so you're going to see low phosphate, and then also hyperphosphate in the urine, and then hypouricemia also in the urine. And then primary, there's a couple different pathways like we talked about that cause the primary. So if you for obstructive uropathy, you'll see a normal plasma Ag with a low nitrate excretion in the urine, and then you're going to see high K and decreased capacity for lower urine in the pH. So that kind of differentiates the two. So for type 3, which is actually a subset of type 1. So once the type 1 is confirmed, you want to evaluate the bicarbonate in the presence of, normal bicarb, and how much wasting there is of it in the system. So type 3 RTA, to confirm that the urine to blood CO2 ratio in alkaline urine is low, you're going to demonstrate the primary origin of the acidification defect. So that's basically talking about how you differentiate between RTA primary type 1 and then this subset, which I talked about in the beginning. It's mostly only found in infants. And then for type 2, for proximal, right? So type 1 is distal, proximal is type 2. To confirm it, the urine pH has to be below 5.5. which is different than the other type 1 that we were talking about. And then for type 4, there's usually a normal GFR. There's absence of structural abnormalities of the kidneys or urinary tract. You want to look at the sodium and potassium metabolism, including plasma renin activity and aldosterone, because you want to confirm hypoaldosteronism or pseudo hypoaldosteronism, which is the body isn't producing enough aldosterone, and that's what's affecting the kidneys, and that's type 4. Okay, so let's break it down to basics. So for management and treatment, the goals of treatment is what you want to do is you want to correct the acidosis by maintaining normal bicarbonate, which is greater than 20, which would restore the child's growth and it will minimize complications. So you can initiate Victra or polycitra depending on the electrolytes that were drawn and the CO2 level, and you can initiate this at 3 milliequivalents per kilogram per day, and then you want to check the labs in 2 to 3 days after initiating that treatment. And then the PDNP will continue to titrate the dose until the goal bicarbonate, which is between 20 to 22, is achieved. And then you want to teach parents that they need to administer the bicarbonate at meal times and frequently, and then before bed. For distal RTA, which is primary, it usually has a rapid result to this treatment, and the bicarbonate should be maintained very easily. For proximal RTA, which is type 2, this usually does require more doses of Victra or polycitra, and it takes a little more time for the bicarbonate level to stabilize. And then type 4, because it's a different causation, the patient's going to need the mineralocorticoid treatment if aldosterone is found to be deficient, and that should fix it. Okay, and then just some management tidbits for type 1. It is rare to have complications, so usually you wouldn't see complications in this patient. For type 2, you do want to screen for hearing issues, nephrocalcinosis, and hypocitraturia in the urine at the time of diagnosis, and then when you follow up with the patient, because that can be complications of this. And then for type 4, you want to be really thorough in your physical assessment of the musculoskeletal and the range of motion extremities in your systems check, as well as to screen for hypocalcemia and low levels of vitamin D in the blood due to the rare occurrence of rickets that can happen with this subtype of RTA. And that's it. There are my references. Thank you so much.